We are going to get started. I am very, very excited about welcoming our speakers today from the Department of Urology. As a almost urologist myself, who had the incredible pleasure of working with one of our speakers in medical school, I'm really pleased to welcome Dr. Benjamin Breyer and Dr. Hiren Patel to HIV Grand Rounds. I'll start with Dr. Breyer, who is a professor and chair of the UCSF Department of Urology, who is also the chief of urology here at CSFG, and a professor in the Epidemiology and Biostatistics Department, who also holds the Taub Family Distinguished Professorship in Urology. He's a clinical expert in reconstructive urology and trauma, and has also advanced the field in areas and domains around prostate cancer survivorship, urologic trauma, and urinary and sexual wellness. Dr. Hiren Patel is a clinical instructor of urology and currently a senior fellow in Dr. Breyer's lab, who's specializing in genitourinary reconstruction and trauma. And really thrilled to welcome them to speak about prostate cancer screening in people living with HIV and lower urinary tract symptoms. So we'll start with Dr. Patel and take some questions in between. Feel free to add them to the Q&A portion in the chat, and I'll read them aloud. And without further ado, let's give them a welcome.
Thank you. Thank you for the opportunity to talk today at the HIV Grand Rounds. For me, this is coming back full circle. I started out as someone that started infectious disease and ended up as a urologist. And Aisha told me that she started off on the other end. So now we're all connected. Thank you. Today I'll be talking to you about something that's important for us as urologists to think about is PSA screening for prostate cancer, and particularly the cross-section of how that impacts people living with HIV. Do I use this? Arrow. Okay. Perfect. Just some disclosures. I am a consultant for a company called Glass Health, and my fellowship is funded by Boston Scientific, none of which impact this talk. So looking at the epidemiology of prostate cancer, prostate cancer has the highest incidence of cancers among men. It's the second highest killer among all cancers. And you can see that with this chart over here, which shows that almost a third of men in 2024 will be diagnosed, new cases will be diagnosed with prostate cancer. And then it's the second killer for men in 2024 as well. Most of these cases, when they're diagnosed, they're localized. So 80% are local disease, which can be managed with watching it, giving radiation, or surgery. Interestingly, when we kind of think about prostate cancer, there's been like this ebb and flow of how much we've been diagnosing prostate cancer. And it largely is with, in the early part of 1975 to like the 1990s into 1995, you saw this really big increase in prostate cancer diagnosis. And that partly was due to the invention of PSA screening and kind of adapting that. And all of a sudden, you kind of see it kind of decrease, plateau, and then decrease further. And that kind of goes hand in hand with how the US Preventative Service Task Force kind of gave recommendations on PSA screening. And so in 1996, they first came out with their first recommendation, which was a D, which is do not recommend. And then it remained kind of in that I and D kind of category where there was insufficient data, and then back to D. And in 2012, again, stayed at D. And so that you could see PSA screening, so, PSA diagnosis or prostate cancer diagnosis has declined substantially. And then finally, in 2018, they kind of modified their recommendation, saying that it's kind of a shared decision between physician and the patient. And with that, there's been quite a bit of controversy regarding prostate cancer screening. And so before I kind of go into that, I wanted to, I don't know, this is supposed to be one of those questions. Okay. Yeah. So I just wanted to poll everyone, at what age do you start prostate cancer screening? It'd be interesting to kind of find that out. Perfect. Okay. Awesome. So most people agree around 50 is the kind of age where you would do that. 55, 60, all correct. 40s, case-based. Okay, and we'll go into that and why that is. And so this is kind of looking at all the different guidelines that have been published on PSA screening. And the top one is the task force recommendation, which came out in 2018. It's currently going through a revision. They have a research study design that's been published, and they're going to look to update it fairly soon. But the recommendation is that it's a shared decision model where you start screening between 55 and 69. At the age of 70, you're aged out of screening, so no more screening occurs. There's no recommendations on if there's a high-risk patient, when do you start screening, the interval of screening, what's the threshold for biopsy. The American Urologic Association came out with new screening guidelines in 2023. Their age is 50 to 69, but there is a high-risk category. And if you're in that category, which includes people with strong family history, genetic predisposition, and African-American ancestry, you would start screening earlier, between 40 and 45. And they recommend a 2 to 4 year interval, depending on whatever is agreed upon. And then there's no biopsy threshold. Similarly, you see them for the American Cancer Society and College of Physicians. But more or less, they're kind of there's agreement on the age where you should start it, which is around 50, and the high-risk population at 40. The nuances are there's a life expectancy clause in the American Cancer Society, and that is with anything. So what are the goals of prostate cancer screening? I think it's important to kind of understand that, to understand these guidelines. It's to identify clinically significant prostate cancer among men ages 55 to 69, partly because prostate cancer is an indolent cancer. It grows slowly. It can affect someone. It can grow over the span of 10 to 15 years. And so it's likely that for most men that prostate cancer is not the reason why they're going to die. It's probably some other cause. And what do I mean by clinically significant? It's that these cancers have pathologic characteristics that are associated with increased progression of disease, metastasis, or mortality. So how do we screen? We use something called PSA, or prostate-specific antigen. It's an enzyme that's secreted by the prostate. It actually helps with liquefaction of the semen, but it's used for screening purposes, and it can be used for assessing treatment response once you started prostate cancer treatment. The interpretation, we generally, it's always been thought anything above 4 needs to be evaluated, but it's really, there's some nuance to that. It really varies with age. So if you have a 40-year-old who comes in and his PSA is greater than 2.5, that to me is, hey, we need to be taking this person serious. They're younger and they have a really high PSA for their age. And so that varies quite a bit. If you get a PSA that's elevated, you should repeat that PSA to confirm that there is actually a true elevation. Most of the time, somewhere between 25 and 40%, 25 to 40% of elevated PSAs actually come back to normal in men. So it's to rule out any spurious reasons for elevated PSA. And so, like I said, there's some caution that you should take when interpreting the PSA results if it is elevated or decreased, and it's to figure out when that actually is real. So it can be elevated in prostate cancer. Someone that has a really large prostate gland can also have elevated PSA. Infections can cause a slight rise in PSA. Any trauma to that area, ejaculation within a week or so of getting a PSA result can do that. And age, as you age, your PSA will rise. So also medications can cause decrease in PSA. So if your patient's on finasteride, then you have to double it to understand that true PSA value. Low testosterone can also cause decreased PSA. Prostate surgery and radiation can also cause decreased PSA. So for the second half of this talk, I want to go through another question and kind of focus more towards the cross-section between prostate cancer and HIV. You have a 50-year-old African-American male, history of HIV, controlled on antiretrovirals. He presents for routine follow-up. He's otherwise healthy. His CD4 count's 300. Do you counsel this patient on prostate cancer screening? Yes or no? Excellent. Yeah, that's, this is the person that should be screened. They're immunocompromised. They're African-American, so potentially high risk population. And this is the age where you would start counseling for prostate cancer screening. So excellent. So just a little about prostate cancer and HIV/AIDS. Prostate cancer is not an AIDS defining cancer. It's not virally associated. In fact, there's some data that shows, and I'll go through that data, that the rates of prostate cancer are actually lower among patients living with HIV. Partly that could be due to the AIDS epidemic. There's a delay in when these patients are getting diagnosed. Screening rates might be lower among these patients. These patients generally have metabolic syndrome, and they might also have lower testosterone levels, and that's why they're not developing prostate or elevated PSAs, or screening is not occurring. There's some data that shows that protease inhibitors actually have anti-neoplastic effects through NF-kappa B pathways, and it's a little bit more complicated for this talk, but there is some anti-neoplastic effect, and so potentially that's why patients aren't developing this. And then regulatory CD4 T cells are actually known to be important for prostate cancer development. And so if there is decreased CD4 counts or dysregulation of the CD4 T cells, does that actually play a role in prostate cancer? I think that's still to be determined. And so if we think about the AIDS epidemic, it really started in the early 80s and kind of continued until the late 90s. But you see there's this large cohort of men that would be 60 right around now and be the patients that would be diagnosed or evaluated with PSA screening, and they have died off because of the AIDS epidemic. And so there's some belief that these are the patients that kind of would have benefited or developed prostate cancer, but they're no longer in the population. That's why the screening, the PSA prostate cancer rates are much lower among patients living with HIV. There's also been quite a few study and cohorts that have been collected to look at, what is the actual HIV, the prostate cancer rate among patients living with HIV. And then there's 4 different cohorts. One is through the VA, which is out of Yale, looking at the veterans aging cohort. And they show that there is this risk ratio that's lower among patients living with HIV. Same with the HIV AIDS cancer match study. They showed that there's significant reduced incidence of prostate cancer among these patients, and same with the Hopkins and the Kaiser Permanente cohort. All of these cohorts have subtleties and why they're unique and different, and therefore, we can go talk about what are the pluses and minuses about these cohorts. But for the sake of this talk, all of them have shown that there's lower rates of prostate cancer. And so, does that really mean that we're screening patients with prostate with HIV appropriately? I think it's complicated. I think the data is actually very nuanced, and I think there's things that we can do better as physicians. So the earliest study actually came out in 2010, and it came out of an urban cohort from Baltimore, and it looked at prostate cancer and PSA screening among men with HIV. And it showed that the screening rates and prostate cancer rates were much lower with people living with HIV. And this was subsequently corroborated with this veterans aging cohort, which is, I think, in 2022 when it was published. But it showed lower screening and biopsy rates among people living with HIV. You can see that over here. Both the biopsy screening and biopsy rates are lower. And then it showed that virally suppressed patients were more likely to be screened. And patients that had there were higher rates of clinically significant prostate cancer found among patients living with HIV. So 54% versus 51%. But this was kind of, it contradicted some earlier literature published from the Kaiser Permanente cohort, which had higher rates of screening among HIV positive men across all age thresholds. So you can see this solid black line, and you see that the rates of PSA screening are much higher among the HIV positive men from 35 all the way to 55. And still, these patients that were screened had lower incidence of prostate cancer. What they found was that increasing age, Black ancestry, and smoking were risk factors for developing a prostate cancer diagnosis. So it didn't have to really do with HIV, but it actually had to do with the determinants of prostate cancer. And so when we think about how does this affect treatment, prostate cancer specific survival is actually lower among patients living with HIV. So you've already been diagnosed, you've already been screened, you had a biopsy, and now you're thinking about treatment. These patients have a lower survival compared to their control cohort. And if you adjust for treatment, the survival becomes non-significant, which actually suggests that disparities in cancer treatment may actually play a bigger role in survival among these patients. And finally, the patients living with HIV are less likely to receive treatment. This is not something to be proud about, but it's the fact. And patients that have lower CD4 counts, African American, HIV that was diagnosed through IV drug use, if you're aged between 45 and 64, you're associated with lower likelihood of receiving prostate cancer treatment. And finally, if you were thinking about what types of treatment they were going to get, patients with HIV are more likely to receive radiation and less likely to receive surgery. And this is kind of thought at the time of this surgery, is that maybe surgeons are more afraid to provide care to patients with HIV just for their own safety. I think that it's a little bit more nuanced. I think there might be a component of that, but also maybe the side effects of surgery, such as erectile dysfunction, incontinence, play a big role in the HIV population. If we think about gay and bisexual men and the types of intercourse that they may want to have. And so in summary, I would say PSA screening should be offered to people with prostates at age of 50, and it can be started sooner if you have risk factors that exist. The screening and prostate cancer rates are lower among patients living with HIV, and that can be due to a multitude of reasons. some of which are biological because of the nature of HIV and maybe its role in, causing prostate cancer pathogenesis. It could be due to social determinants of health. Are there access to care issues? Are there disparities that we're not identifying? And finally, the disparities that that already exist that are evident that patients aren't getting the appropriate level of care or not congruent with the rest of the population. That also might be leading to these differences in rate. Prostate cancer treatment disparities exist among patients living with HIV, and I think we should be mindful of that when we provide our care and counseling. And that's part when we start that screening process and the biopsies, it starts over there, I think, and then kind of carries it all the way through the specialist as the urologist providing care as well. So happy to take any questions. Thank you.
Thank you, Dr. Patel. I will walk around with this mic. Question.
Thank you so much. That was really great. I had a question because and I'm really just curious about what you said about the increased rates in people living with HIV and trying to explain it by multiple factors, because that isn't something that I've traditionally seen necessarily. And in breast cancer, there's some mechanism of possibly lower rates in those living with HIV of breast cancer, with the breast cancer cells carrying the CXCR4 receptor. So is there any, it could be just like you said, increased screening or social determinants, and it can go either way. But is there any was there ever any hormonal receptor or anything that came up ever with prostate cancer that people with HIV would have higher CXCR4 or CCR5?
Yeah, so I think the regulatory T cells, the CD4 positive T cells, they play a really important role in prostate cancer pathogenesis. It's still being uncovered why that is. I think there's FOXP3 and these other pathways that are important for prostate cancer development. If there is dysregulation because of HIV in these pathways or in these cells, that they may potentially be affecting prostate cancer development. I'm not 100% sure, and I don't think that's mechanistically been identified, but that's one of the presumed reasons.
And one follow-up question to echo that, to hear your take. It sounded like there are some data that suggest lower incidence in people living with HIV, and then some, it's like there may be conflicting data.
Yeah.
And you mentioned the PIs as another mechanism of maybe those.
Thanks, Hiren. Great talk. Can you talk to us about what's the role of obtaining a PSA in someone that comes in with urinary symptoms? Is that screening? Do you need to do it? What's the purpose?
Oh, excellent. Yeah, generally, when a patient comes in with urinary symptoms, it's kind of figuring out what those symptoms are, and that kind of will go hand in hand with what you're about to talk about, the lower urinary tract symptoms. But it's to figure out what those symptoms are, and is that actually caused by prostate cancer? Oftentimes it isn't. It's the symptoms that we think about are blood in the ejaculate. Is there some other obstructive symptom that might be causing the urinary symptoms? That's usually due to BPH, but we don't use PSA for that purpose when someone has lower urinary tract symptoms. So.
Yeah, I guess I would just say we typically will get a PSA when someone has urinary symptoms because we do want to rule out prostate cancer, but it's not commonly the cause of the urinary symptoms. It's usually a silent disease.
Mm-hmm.
Any other questions? Yeah. Maybe it's okay if I go to Matt and you. All right. Yeah, he just.
Thanks so much for a great talk. So I guess thinking about kind of like gold standard for cancer screenings being randomized trials, ideally showing mortality benefit. I'm not aware of any data that shows there's a mortality benefit from doing this type of screening. I wonder if you can just speak to that and sort of how we weigh sort of the data from randomized trials and concerns about overdiagnosis and thinking about these screening discussions we're having with patients.
Yeah, so there's been a lot of trials. There's been several, some started in America, some in Europe. And they've shown that the American trials had the PLCO trial showed that there was, that there is some benefit with PSA screening. The European trials were much cleaner trial in terms of having specific screening intervals, no contamination. So anyone that was screened was going to stay screened. Anyone that wasn't going to be screened didn't stayed in the cohort. And they showed that there was some added benefit of PSA screening. And it was recently published. I think last year that the latest iteration of that from the European trials, and it showed that there was added benefit. And I think the number needed to screen was somewhere in the magnitude of hundreds. Don't quote me on this, but it was somewhere in there. So I think there is benefit of PSA screening. I think the conversation needs to start early, like in the 50s, and it's a shared decision-making model that's advocated by all the guidelines.
We debate this all the time. We've looked back at those trials and so many are flawed. And Matt and I debate this. I would do a call to talk about not just mortality. It's not about death, about morbidity and all the suffering that happens with people who present with late disease. And you guys are leading the charge, but we see it. And we all have our horror stories of somebody who was overdiagnosed, but I would argue there's a lot more people who have suffered for the other extreme.
Yeah. Agreed. I think just to kind of piggyback off that comment, I think it's PSA screening, again, is to rule out clinically significant cancer. It's cancer that's going to cause metastasis, mortality. It's going to be something that progresses. And those are the patients that we really want to diagnose. It's not the patients that have low indolent cancer that's not going to be of any malignant potential. So.
I just want to, my questions were around that shared decision making. We use that term all the time. I think it's incredibly difficult to do with prostate cancer screening. I mean, we're all having a very nuanced conversation. And then, I know with my father, he said, I don't want to have cancer. I'm like, well, that was a good conversation. But it is really hard to have these conversations, and you want to, I don't know, I would welcome knowing if there's good published guidance around how to have that. Because I think we use that term a lot. I think shared decision-making, especially around this specific topic, is really hard. I think I do a bad job. And I think we're all trying, but it's challenging.
I really think it depends on the patient population you're working with and the amount that you can converse about this kind of freely and kind of in a shared decision-making capacity. Some patients just want to be told what to do. Some patients want to kind of walk through that road with you in the screening process. It really depends. And I think that's where kind of the shared decision-making model is. It's more about the nuance of like who's across from you when you're talking to them.
Any other questions? Oh, Karina, did I get?
I agree with Annie. It's a very hard conversation with my patients to say, what do I do? Should I do, doctor? But I think the question, and I've done a lot more, I've like gone through those ebbs and flows of PSA screening and have done a lot more recently, and have been very impressed by the thoughtfulness in the decision and the new diagnostics and decisions that go into actually doing a biopsy. And I think my question for you is sort of, I think some of us would love to hear more about sort of how that decision is made. Like, I feel like everybody I send to you gets monitored well and not biopsied, which I think is great. And so it's made me more encouraged to do more screening and that to minimize those secondary harms. But I'd love to hear a little bit more about sort of like what proportion end up getting biopsied and sort of other decision-making.
Yeah, I can speak to that a little bit. I think we have great radiology support here. We also, so that means most, if not all, of our patients that have elevated PSA will get an MRI. And so right there, you're going to really separate out a lot of people when you look at their risk based on their PIRAD score. And if it's indeterminate, then there's urinary and blood markers that can be sent to also help quantify risk. And all those things are incredibly helpful. And the other thing I would, so yeah, it really depends on the cohort, but it's a smaller percentage these days that get a biopsy because I've had a patient that died after a biopsy here at the General. So it's not it's tends to be a low risk procedure. This poor gentleman had diabetes. He ended up getting a psoas abscess after getting seeded from, somehow the needle transversing the prostate into the urinary tract. So he got urosepsis, seeded a abscess, terrible case. So we don't take doing the biopsies lightly. There's been a lot of really great work by a woman named Ninika Palmer, who she's a medicine primary appointment, but also in urology on decision-making in African-American men. She leads a lot of support groups in the Bay Area for African-American men with prostate cancer. And her work has really been around, once you get the diagnosis of prostate cancer, there are a lot of decisions that have to be made. Do you do watchful waiting? Do you do, or other active surveillance? Do you get radiation, many different types? Do you do surgery? And really, the General here has actually done a lot of really, I think, seminal work in that area led by her, informing nationally how we treat our patients. And so, good stuff.
Thank you both so much. We have a couple of great questions from the chat, but for the sake of time, let's move on and have Dr. Breyer speak, and then we'll come back to these at the end. Thank you.
All right. Well, greetings, everybody. Thanks for the opportunity. This is really fun. When I was a junior faculty member, Dr. Appa was one of my students, and we actually have 2 papers on PubMed together, which is kind of cool. And so really grateful for you all to host me back. I haven't been gone long. I was the chief here for about 10 years in urology. So sorry if you had any bad experiences with us. It's my fault. And then just 7 months ago became the chair of urology for the department here. So these are my disclosures, really none germane to the talk. One industry relationship, I do prosthetic surgery, so penile implants, incontinence surgeries, and this company makes those devices and helps support our fellowship. All right, so this is a case. 52-year-old man, HIV, presents with urinary frequency, urgency, no urologic history, normal phallus. You do a DRE, it seems benign, it's not a big gland, and you get some labs, they all look fine. This is like really a surgical H&P right here, right? So it's like so sparse. So what do you make of this? I mean, I think you need to understand a little more about how often this is happening, how bothered the patient is. Is this a big deal? Is this a little deal? So how do you do that? Typically we'll quantify these things with a PROM, patient reported outcome measure. Now you don't have to do this, and full disclosure, guideline concordant care, at least in the urologist's office, you should be doing this. In my office, often we don't, just because it's hectic, and but the nice thing about this is it allows you to see how they respond to therapy. It allows you to have a really good sense for how bad the condition is. And there's also an 8th question that quantifies quality of life. Like if you were to live with a condition for the rest of your life, how bothered would you be? And so that gives you a sense for, hey, should we start medicines or should we just do conservative things? But one of the interesting things about LUTs, or lower urinary tract symptoms, is there's a lot of different reasons that you can have lower urinary tract symptoms, and they're extremely common. And so not all of them need to be treated, but there are many different reasons that we have lower urinary tract symptoms. And sometimes it's very common for people to kind of think BPH, lower urinary tract symptoms, like the same thing. But so there's BPH, which is the pathologic diagnosis of removing some tissue, looking at it under the microscope. There's prostatic obstruction, which is a common thing that many men experience as they get older. And that's where the prostate's like a donut and it grows into the lumen and it becomes harder to pass the urine. And typically that leads to obstructive symptoms. And you'll hear me talk about the irritative symptoms and the obstructive symptoms. The obstructive symptoms being weak stream, difficulty starting the stream. So that's called hesitancy. Or then there's intermittency or intermittent stream, where it's like a staccato peeing motion. And then there's nocturia, which is like a totally different animal. It's like, like an animal from Australia when you have the rest of the animals from, I don't know where I'm going with that analogy, but it often has many different inputs, often associated with systemic diseases and less so kind of local urinary tract things that can be managed surgically or medically. So I see a lot of nocturia, and it's primarily behavioral therapy that we recommend, a lot around when people consume their fluids, and then sleep hygiene and getting ruled out for sleep apnea and these kind of things. But then there are all these other little things that can be causes of urinary symptoms. Bladder tumors, very rarely prostate cancer, a kidney stone that's fallen down and is in the like right at the end of the ureter can lead to really significant LUTs. Sometimes there's someone that has infection. Sometimes there's someone that has something in there, whether it's a stone or a foreign body that was left from a surgery, or we've taken crack pipes out of people. So, you never know. Yeah, that's a true story. So all types of different reasons that people have lower urinary tract symptoms. So when I was a resident here, and to date myself, just seeing a lot of guys in the clinic that had HIV and LUTs, and I was like, wow, this is interesting. Has anyone studied this? And actually, the seminal paper, then there were only like two. One of them came from UCSF, from former chair Dr. Emil Tanago, and he did urodynamic studies of people with HIV and AIDS, and a lot of them had underactive bladder. So the bladder stopped working and they retained a lot of pee. I actually was very interested in this as a resident, got a little grant from the Sexual Medicine Society, and did a sort of a suite of studies looking at the impacts of HIV AIDS on urinary wellness and also sexual wellness in men who have sex with men and women who have sex with women. And really the thing that I was most excited about was this idea of, do people with HIV or AIDS have worse urinary symptoms? And so at the time it was novel, it's not novel now, but we distributed a ton of surveys through Facebook. And Facebook was sort of this new thing then. And, but it was a cool way to do some targeted sort of survey distribution. And really, we found some interesting things. One, we found that there was and so this is probably the cohort, I think, is around 4,000 folks. And the worse your HIV status, and this is a very blunt descriptor or stratification, the worse the disease. And you can kind of see it across every different important urinary symptom, whether it's frequency, whether it's nocturia, whether it's the ones related to BPH. And so this was very interesting. And we modeled this, of course, adjusting for different risk factors, and those that had an AIDS defining illness were highest at risk, 3 times the odds of having progressed and presented with endorsed having severe LUTs. So this was interesting. And I don't know if it mechanistically unclear whether it's related to something around the medications, whether it's related to something intrinsic with the disease, but there's something there, there's something to it. And I think we've all experienced that as providers. This is just sort of normative data, like 30,000 men and what they experience, all ages. And so, you see that one of the prominence and prevalence of these things can be extremely high. This is dribbling, which doesn't seem like maybe that big a deal, but it really can vex some people bad. And so that they hate that. But 45% of men endorsing dribbling, and just under 10% saying it's really severe and quite bothersome. But you can kind of see things like nocturia. And so for me, when I'm counseling someone with nocturia, it's really important to kind of share with them what the normative data is. That's, I think, helps inform them. A lot of people present with urinary symptoms and they're worried that they have a malignancy. It's also important to kind of talk to them about that risk and the likelihood of that. And often they'll come with a PSA. And so you can kind of have a discussion. There are many modifiable and non-modifiable risk factors for BPH in male LUTs. I think the good news is that there are a number of things that can be improved with diet and exercise. There are certain things, some people, it is genetic. Some people have massive prostates, and that's an often genetic. Geography has to do with diet. But interestingly, at different, as you get closer to the equator, the risk of UTI is higher because of the hot weather and dehydration. Briefly to talk about leakage. There's three types. You can have overflow, where essentially you're just not emptying. You have like a liter in your bladder. When you twist, you leak. When you go to bed and the sphincter, the voluntary sphincter tone relaxes, you leak. Then there's stress leakage. That only happens really after a surgery. So he had a prostatectomy or a TURP or whatever. And then there's urge incontinence. That's the type of incontinence that you have when you feel the need to pee. It's sudden and strong, and that's called urgency. And when it's associated with leaking before you get to the toilet, that's called urge incontinence. For everybody that has LUTs, I think it's an important first discussion to talk about behavioral modification. Sometimes we give patients voiding diaries and we learn they're drinking like 5 liters of water a day because they thought that was healthy. And you can have a pretty profound impact. Just tone it down just a little bit. But we also counsel folks, you're going to have more overactivity or bladder irritation if you have spicy foods, acidic foods, lemons, limes, tomatoes. My buddy here is laughing because we say this stuff in clinic so many times each day. Caffeine, alcohol, these things will make you pee more often. They'll make you pee more urgently. And so for my folks that are really bothered by these symptoms, we just ask them to kind of reflect, especially the very interesting thing about urinary symptoms, and we'll get to this a little bit later, is there's a big ebb and flow. So you all have seen this as clinicians. Someone may be very bothered one day, and then 2 weeks later, it just goes away. And a lot of times we don't know why that is, but it's probably multifactorial. And that's another thing that I like to tell people about is that these just came on, they may just go away. Let's try these things. Let's avoid these foods. Some days are worse than others, and maybe reflect on what you ate in the last 24 hours and you can find a connection. Kegels are not really helpful for anything other than stress leakage. So someone had a prostatectomy, Kegel exercises are going to be really helpful. This is for men. Now, it's different in women that are leaking. There is pelvic physical therapy for some lower urinary tract symptoms. Some guys can't relax their pelvic floor, and so they have obstructive symptoms, even in the setting of no urethral stricture, no prostatic obstruction. And so they go to the physical therapist, and the physical therapist teaches them how to relax their muscles down there. There's also, they do like myofascial release by, doing a DRE and feeling the muscles along the pelvic floor and teaching folks how to relax. And so that can sometimes be helpful. There is also physical therapy for suppressing when you feel the urge to pee and trying to, with cognitive behavioral therapy, think about other things. And that can sometimes be helpful for some people with overactivity. And I'll go over, there's a lot of different medicines that can be used for folks that have overactivity. I'm interested in this idea that, preventative care for this kind of thing. So eating a plant-based diet has been associated with improvements in erectile dysfunction, but it's also been associated with improvements in lower urinary tract symptoms. This is a study of obese men with type 2 diabetes, and an intensive exercise intervention led to less lower urinary tract symptoms. So whatever we can do to help our patients work out, be fit, be active, eat well, that's going to help their symptoms. But, that's sort of like no brainer, right? That's with everything. So I think it's, if someone has no evidence of infection, if someone has no evidence of bladder stones, significant urinary retention, or renal compromise, you don't really need to do anything. It sort of depends on how bothered they are. So some people, they would rather not have medicines, they would rather not have therapy, and they'd rather just be watched. So they, you can watch them. They can be seen in the urology clinic if their post-void residual is elevated. Otherwise, they can just sort of kind of check in if they have problems. We don't commonly, it's actually recommended against. You don't need to get a creatinine with someone that has urinary symptoms. But if in the sort of monitoring their overall health, the creatinine is, a kidney function is seen to be abnormal, then you can kind of make a connection with the urinary side of things. And those folks do need to be treated. On the other side, so if someone has BPH symptoms, so these are the ones that are the obstructive ones, it's hard to start the stream, empty. These folks, we typically will start with an alpha blocker. So tamsulosin's generic, that's the one we typically go to. It's a selective alpha blocker. We used to use some older medicines like Hiren or terazosin, where you'd have to titrate up. Those aren't commonly used anymore. If the person has a gland greater than 30 cubic centimeters, you can use a 5-alpha reductase inhibitor. I'll talk a little more about those. There is some data that shows that there's less retention events when someone is given the dual therapy of tamsulosin or a 5-alpha reductase inhibitor like finasteride or dutasteride. And then those with overactivity, you can use an anticholinergic. You can use the newer beta agonists, which we're getting for our patients here at the General, like Mybetriq or Gemtesa. These can be harder to obtain, but certain plans here, you can get it. And then the other one that's generic now is tadalafil or Cialis. So Cialis is FDA approved, of course, at 20 milligrams for erections. It has a 36-hour half-life, but it's also FDA approved for urinary symptoms, particularly overactivity. There's a lot of the PD5 receptors in the bladder and in the prostate, in addition to being in the penis. And so you take the 5 milligram, and that actually helps a lot of guys with urinary symptoms that are nonspecific. So this is like our big famous urology trial that was in the New England Journal for urinary symptoms, and just shows that 5-alpha reductase inhibitors, when combined with alpha blockers, lead to less need for a surgical intervention. These are data just showing that you can use a lot of these medicines in different combinations they're well tolerated, and you will see improvement in symptoms. We actually just wrote a paper that we're submitting on the fragility of these trials in OAB and overactive bladder. where it's the number of patients that need to go to the other side of the outcome for the study to be null. And I will, as a sort of editorial, some of the medicines are very helpful for some folks, but some of the medicines do absolutely nothing. And then our patients are kind of on these things and kind of marginal benefit. This is a paper we wrote on litigation around 5-alpha reductase inhibitors. This is particularly in guys that have take it at the 1 milligram dose of what's Propecia for hair loss. And I'm not interested in this because I took it, don't worry. So the issue is these guys take it for a short period of time and they feel, and many believe this is true, that they stop it and that they have prolonged ED. They have prolonged issues with sensation in their genitals. Every guy that gets this medicine should be informed 10% of guys will have decreased libido, 1% will have ED. I always tell my guys, there's also this litigation out there that it could be long-term. I actually haven't seen it, but if we have any of those complications, we should stop the medicine. And again, 5-alpha reductase inhibitors only want to do if your prostate's at least above 30. This is a study that I did with a guy in medicine, Scott Bauer, who is also in our department. And it's an N of 1 looking at tamsulosin. So basically, we had a cohort of folks that took a placebo or took the drug, and every day these poor people would fill out a prom about their urinary symptoms and their side effects from it. And this is sort of that editorializing, like we get somebody on a med for urinary symptoms and they never go off it. We should, I think, use med holidays in treating LUTs, because a lot of times guys will figure out they actually don't need it. But this is sort of concrete evidence of that. You can see that, you know, these folks really got a lot of benefit from the medicine. But some people actually had worse symptoms when they took the medicine as opposed to the placebo. So we're writing this up now, so hopefully this will be a nice contribution. This is sort of the schematic of the prostate. This stuff right here, this is sort of the stuff that's blocking you. That's the meat of the prostate, and this is where the cancer happens. So it's like a navel orange, and the orange part is where the BPH tissue is, and the outside is where the cancer resides typically. And that's why, you know, in some ways the DRE may be helpful. There's actually a lot of data around PSA levels and whether a DRE is useful or not for prostate cancer screening. And typically if the PSA is under 2, a DRE is not going to be a helpful study. We do a big workup if someone's getting considered for surgical intervention. We want to size the prostate. We can do that with imaging or with a scope. There are a number of therapies. This is a very confusing slide, but the ones that we do here include UroLift. So this is one of the minimally invasive ones, tends to be well tolerated, often a bridge between sort of meds and some invasive procedure that really removes a lot of prostate tissue. This is not something we have here, and I don't think it's a big detriment to our patients, but this is a thing where you put in steam to the prostate and the prostate just melts away. This is another thing that is out there. So there's been a sort of an explosion in these, what they call MIST. It's these minimally invasive surgical techniques for BPH. This is something we offer here, and it is a gold standard treatment. There's TURP, which is sort of older. We're doing fewer of those and more of these HOLAPs. That's where you take a laser and you get in a plane here and you sort of enucleate the glandular tissue. So just the surgical techniques are important in folks that have severe obstructive symptoms. Of course, they're important for folks that can't pee altogether. We have to do something to get the catheter out. They're not as good for overactivity, but if somebody has a residual of 300 and they're peeing every hour and a half, maybe they have a 500 bladder capacity. So their functional capacity is greatly reduced. And in those folks, if you remove some of the prostate tissue, you can improve their symptoms. Love to take questions.
Thank you so much. Hey, any questions for Dr. Breyer?
Not as hot a topic as PSA, I see.
Yeah.
Just more of a comment. You do a lot of education in your e-consults. It's super helpful for us when you put data in there. You do the basis of your recommendation, and this can be confusing for us. When there was a recent Annals of Internal Medicine paper about this, I don't know if you don't read Annals, but it was like complicated. But we're with you. We see this a lot, and please keep doing in your e-consults, helping us learn as we go.
That's great to hear, and appreciate that feedback. Yeah. I think the e-consult's great, and I did the e-consults for 3 years at one point, a long time ago, and I had a lot of fun interfacing with the primaries on different topics.
Thanks so much. This comes up so often for our patients, so it's really helpful. So my question is about sort of side effects of BPH meds for urinary retention, and sort of what you recommend for older adults who are having more polypharmacy, maybe dizziness, things like that. What's the best approach in those situations?
Well, that's a tough one. And if they are in retention because of BPH, probably putting them on a 5-alpha reductase inhibitor after counseling them, which, takes time, right? It actually takes a couple months for you to get this 30% reduction in the prostate volume. The medicine that we have, of course, concerns about is tamsulosin is probably going to be the best one. So we advise that it's taken at night, right before bedtime, and that when inevitably these folks are getting up 3-4 times a night. Now you can counsel them to have a bedside urinal or commode. Even if it's an ensuite bathroom or whatever, the walk over there can be we know that folks that have nocturia have more hip fractures. So what he's getting at is there's 2 big complications or side effects of Flomax, tamsulosin. One is retrograde ejaculation, and you should warn folks about that because a lot of people, they're not down with that, and it's really kind of distressing. The other is this sort of orthostatic hypotension. And so especially with getting up from the reclined position, you get dizzy, you fall, you can hit your head. It can be quite a morbid thing. And so bedside commode, but then also warning folks about this. The biggest period of time that you have those is typically the first week. So there is an acclimation process where your body just gets used to it. But I'll ask my guys to just sit at the side of the bed for a moment before they get up. Yeah.
Thank you. Any other questions? I'll ask one question, which is, can you talk about the role of DRE in the sort of LUTS evaluation?
Yeah.
Obviously in urology, it's different, but do you suggest that essentially all of us do a DRE at sort of time?
Yeah, that's such a great question. And it's an easy physical exam thing to do. For some, it's super invasive. They just don't like it. And, true confession, I don't do a ton of DREs in my practice because a lot of times they'll have, if someone has an elevated PSA, I'm going to get an MRI, and that's going to be a lot more sort of informative. But if we're ruling out prostatitis or other things, the DRE can be really helpful. So if you put your finger in there and it's like exquisitely tender or boggy, you can actually feel like it's hot. That you're dealing with some type of prostatitis situation. It is valuable to give you a gestalt of size, but you can imagine if the gland's like this, you're kind of feeling this sort of quadrant of it. you're really not feeling, and if you only do a few every now and again, it may be harder to kind of get a sense, but there, and I mentioned earlier, in terms of cancer screening, you're advised to do it if the PSA is greater than 2, but below 2, anything that's in there is going to be small enough where it's been shown that so insensitive to not even bother. Yeah.
Thank you. I think we'll wrap up. Thank you both again.
Thanks, everybody.